I was struck by two, I mean, many aspects of what you said, but by two in particular. The first is actually the extraordinary resilience of health systems and community-based health approaches that, the countries in the most extraordinarily difficult circumstances, civil war, breakdown of law and order, that somehow these systems come out in a way that they're equipped to, to deliver quite significant gains. And I think the Sierra Leone and Nepal story are examples of that. And on the climate change map that you showed, I do wonder about the way we think about climate change. I think part of the problem is we keep thinking of these long-term scenarios. It's 2050, it's 2070, it's 2080. Yeah. But these changes that map captures are going to manifest themselves as small incremental risks to people who are desperately vulnerable. And if you superimpose that map on a poverty map, the average person below the poverty line in Africa lives on 70 cents. Most of them are smallholder farmers. If you superimpose a 10% productivity loss, I mean, that is a health catastrophe in the making. So, it does seem to me that focusing on that aspect of resilience and health and climate is very important. So, I'm going to throw it open for discussion now. Before I do that, there's one thing I should have mentioned. I can see a lot of you are tweeting away desperately while this is going on, but there is, in fact, a hashtag, which is health progress. So if any of you want to either follow the debate or contribute to the debate, that's the place to do it. So what I'll do is I'll take questions in clusters of 3 or maybe 4. I would like people to keep the questions relatively brief if possible, no long speeches. We are going to run on until about 12:45, and then so which gives us plenty of time for discussion now. So over to you. So we've got one question here, and then one, and then 2 in the front row. No, not you. You can. Yeah.
Thank you very much. My name is Fiona Doobie. I'm a independent consultant in public health. Thank you, all the speakers, because there are masses of questions, and I'm just going to focus on 1 or 2 important points that I think have come up or not come up. I appreciate the point Fiona made about the problem of supply, service supply. Two examples would be in Malawi, where women are fined if they don't, their institutional delivery rate is high, but women are fined, poor women are fined if they don't go. And the outcomes of those institutional deliveries are very poor, very, very high death rates, both for women and children, because the quality of services is very poor for lots of reasons. Ethiopia, fantastic scale up. If you go around in the rural areas, the hospitals are empty. Their institutional delivery rates are appallingly low at about 10%. So the scale up has not resulted in commensurate increase in uptake of services or better outcomes. And the huge number of women who are trained to do delivery have never even done one. So lots of problems with that. I think task shifting is really important, but it's got to be supported by continuing CPD, which is where mobile phones have been really good in Kenya, supporting women, for example, in abortions. I think that decentralization is great, but districts are overstressed with lack of budgets. And Malawi is a case in point now, withdrawal of aid and the impact it has. So we're very aid dependent. And the final point I'd just like to make is on accountability. We haven't talked about accountability, but we do have the global health accountability framework, and I think that's really important. Why aren't countries spending their 15%, etc., accountability right down to the community? I think it's really important.
Thank you very much. Then 2 questions right in the front row here.
Hi, I'm David Molyneux from Liverpool, and just like to thank the panel for their excellent contributions. And I have been involved with Fiona and Romina in making comments on their material that they published. I just want to make one comment, or 2 or 3 comments actually. One about the unit costs of the NTD program in Cambodia. I think it's really important to say that the unit costs as calculated by Antonio Montresor from WHO for the deworming program were 0.2 to 0.3 cents per child treated. So it's an incredibly low unit cost. I think to supplement Moses' excellent comments about Sierra Leone is that one of the drivers of, and he'd be able to give us the figures, we forget that filariasis is also, control of filariasis is also driven by bed nets. And I think that the bed net factor, certainly for the next few years while they're still efficacious, and there's a limited efficacy in bed nets certainly, has made a contribution to the figures that we've seen in Sierra Leone. But one point I want to make about, and linking this Nepal presentation about the real improvements in maternal mortality, and linking it to NTDs, is there is some work done in the Terai by the Johns Hopkins group, published in The Lancet in 2004, which showed that twice a year albendazole, 2 doses of albendazole to second and third trimester women in areas of high to medium hookworm prevalence reduced infant mortality at 6 months by 40%. This is purely the impact on anemia. And you're giving iron and folates. The question really I have is, are you giving albendazole to these women in these very vulnerable settings? Because that is a fantastic increase in infant mortality, reduction in infant mortality. And this is a real policy issue. You can give albendazole to pregnant women at that stage in their pregnancy.
Thanks.
So it links the maternal mortality, because one of the key drivers of infant and maternal mortality is anemia. And schisto and hookworm are the primary drivers of anemia, not only in Nepal, but in much of sub-Saharan Africa.
Thanks, Toby. Actually, there was one question over here. Sorry, thank you.
I'm Clara Saville from The Brook, which is actually an animal health NGO. I've come to learn from you guys. I just had a question for Professor Haynes, talking about the quality of these services and focusing on the community health workers. We use community animal health workers. What are your thoughts on the level of training that they should receive, and how much support should they get from professionally fully trained doctors in these sectors?
Thank you very much. And then, are there any over this side? One right here, and then we'll go back to the panel.
Thank you very much. I'm Yobi Zhang from Helen Keller International. And I'm very pleased to be here and hear my colleagues talking from Cambodia, and also hear the Moses talking about Sierra Leone. I just want to make a comment on why NTD program is so successful, particularly in Sierra Leone and also many other countries. I think key thing here is the role of international organizations and NGOs played in country in assisting the programs. And a huge lesson has been learned, like from Global Fund. Without very strict monitoring of the fund, and we have seen so many people from Africa, including many health ministers, are in prison now. So for the NTD programs, an NGO play a key role in managing the financial aspect and provide a technical assistance to the national programs, making sure everything is done correctly and try to minimize the risk of mishandling of the fund. As one comment. I have a question to the panel. I saw Fiona mention that CDD's incentives, how we incentivize, is that the correct word? Incentivize the CDDs. In the NTD programs, mostly the volunteers, they are not paid. But we growingly see the attrition. The turnover is so high because they are not paid. At the global level, how we can advise the country to develop a national policy to compensate that, their loss of income by devoting their times. So I want to hear from the panel. Thank you very much.
So I'm going to give everyone an opportunity to respond to whatever you want to respond to. But I think Fiona raised a really important broader question that, Andy, you ended by talking about how important these targets are, sort of framing normative goals, but also as a practical benchmark. But targets can also produce perverse outcomes of that type. And I guess, I'd be interested to understand from the health sector what the risks are with targeting. That, is it creating perverse incentives for policymakers? So why don't we start at this end? Joe, do you want to?
No, I'll defer at this point.
Shilu.
As Sir said that albendazole, we also provide albendazole on 4th month on pregnancy to all pregnant women, and 2 times in the year, I think April and October, after 6 months, up to 5 years, from 1 year of age to 5 years of age children, we are providing albendazole to all children up to 5 years of old. And we have, Madam said that task shifting. In Nepal, nurses also do abortion up to 8 weeks of gestation, and with medical abortion up to 9 weeks of gestation. Even in health post, now we are scaling up. We have total 75 districts. In 27 districts, even auxiliary nurse midwife, they perform medical abortion because they are trained in manual vacuum aspiration for post-abortion care. So if bleeding occurs, they can manage. And we are we now trained medical officers for to do cesarean sections. Tax shifting is there, and in many other things also we have tax shifting because higher level medical graduates, they do not stay in rural areas. So we are gradually tax shifting in all things.
Thank you, Sheila. Fiona. Actually, before you speak, Fiona, I've just been reminded that I need to ask. We have a large online audience, so if people want to post who are online, if you want to post questions in the chat room, then I can relay them to the panel. Thank you, Fiona.
Thanks for your comments, Fiona. I think it's really nice to have a sort of injection of reality, I suppose, as well, from other countries. So I think that was really great to hear some of the actual, on the ground issues faced in different countries from beyond the ones that we were speaking about. I think we haven't spoken about it here, but I think the issue of sort of new technologies is really important, and I think it's an expanding area in which I think we need to look at and see how we can make best use of those. I don't know the figures now, but I think huge amount of people in African countries now have access to mobile phones, so I think we need to work on that. Decentralization, yes, obviously the countries that we have looked at, it has worked, it seems to have worked, but that, yes, we totally agree, it doesn't necessarily work, and there are huge amounts of sort of implementation problems at what we are calling the meso level or the subnational level. And I think, some of the things that we are thinking about, and maybe what we would write up in our paper would, how do we bridge these gaps between competing resources and budget allocations between different sectors at that level. So, that could be something that we would look into in a decentralized structure. In terms of the community drug distributors and attrition, I think what was coming from our case studies is and also from the Mozambique study, Mozambique as well, is that they're becoming hugely overburdened. And I think people, because they've been so effective at reaching out, people are thinking, trying to use them for all sorts of different things. So obviously, this can't continue. So I think, yes, we do need to think about how we motivate them, how we incentivize them, and as I was also saying, how do we bring them maybe more into some sort of formal system and recognize them more formally. I think in Sierra Leone they are doing things like giving them T-shirts and other incentives, but obviously that's not sufficient. So I completely agree, and it would be great to hear from others, maybe other experiences of working with volunteers as well.
Thanks. Moses, could I maybe throw one in as well? That in the past we've had this protracted debate about horizontal versus vertical provision and whether there's a potential trade-off between the two. I just wonder in the case of Sierra Leone, because clearly, there's been extraordinary progress on the neglected diseases that you mentioned, but less so in many other areas, for example, maternal health and I think child health as well. And I just wonder, is there any sense that there are tough choices to be made, or are these potentially complementary initiatives and reforms?
Yeah, I think, thank you very much. Talking about vertical programs and how we integrate one, and especially with our cross-sector approaches, I think, working within the framework of some of these successful programs, like maternal health child health program, is really important. Now, what made the integrated control of NTDs successful and scaling up accelerated is because there was a successful, well-supported river blindness program that was there before. So they built onto that. And what happened is that it was very easy with Sierra Leone coming out of a war situation and everybody starting sort of the governance structure being rebuilt. It was just now we have one program manager for neglected tropical diseases instead of having different ones. In a lot of countries like Malawi, it is still difficult to say who will give up the position of being the Shisto person or the LF so that we have only one person. So that's worked. One of the slides I missed out, and also I want I had a clip of last week a national newspaper news for this maternal child health week in Sierra Leone, and one of the things they said was that they would be distributing about 3 million bed nets. So we use this to drive all these activities, and obviously Professor Molyneux is right. Bed nets in Africa are really one of the strongest determinants of the success for control of lymphatic filariasis, because the Anopheles mosquito that transmit malaria is the same mosquito that transmits lymphatic filariasis. So that is a very powerful and strong one. Now, I just wanted to, Yaobi's thing about incentives for community volunteers, it's how can this be tackled? Now, the program was that these are volunteers and you don't pay them, and we've really struggled because there are lots of them, 29,000 in Sierra Leone. And even though they are not paid, but just funding workshops to train them is the highest budget line in the implementation support that we give to these countries. So, but what happened recently, like the head of the onchocerciasis program went to Cameroon because we are now trying to get national governments to get involved. And the way this was sold was that the drugs that are being donated for neglected tropical diseases cost a lot. But people don't usually take into account the cost because it's not being presented there. So the APOC director went to the politicians in Cameroon and said, do you realize that every year the drugs you get in donation is worth $20 million? Okay, you have provided $20 million. What are you going to do as your contribution to make sure that this will be distributed? And the Cameroon government committed $2 million for incentives for CDDs and that. So these are ways that are now coming up to extract this.
Thanks. Andy, do you want to take those themes up? I think there are a couple of specific questions on workforce-related issues as well.
So can I first of all just mention, respond briefly to the Ethiopia point, which I think is an important one. And it's quite common, actually, as countries develop that things develop a bit in sequence. So infant mortality often falls before maternal mortality, obviously, because you require a much better functioning health system for reducing maternal mortality. And I happened to be in Ethiopia just before Christmas and at the Ministry of Health, and it's very clear that the Minister, Dr. Cassetti, is very, very aware of the maternal mortality problem. And they're adopting a number of approaches, one, of course, which is to massively scale up their medical schools. And this is a very brave it's a very brave initiative, and I asked him, well, what about the quality of the graduates coming out? Because often these are quite, the medical schools are very small, they don't have experienced teaching staff. And he said, well, we've been pleasantly surprised by the community feedback. I mean, this is obviously anecdotal, but the gamble may be paying off, we will see. But this, in future at least, should allow a lot more skilled birth attendants, medically qualified, at the district hospitals. But other countries have taken different perspectives. I mean, Mozambique, for example, as many of you know, has trained up technikos de chirurgia. So these are not qualified doctors. They've made the deliberate decision not necessarily to train. They do train medical doctors, of course, but they also train these surgical technicians. And the reason for that is that the evidence is that they're as good on specific procedures as trained doctors, but they're much less likely to go abroad because they're not on the international market. So different countries have different approaches. Second question was about quality of community health workers and length of training. There's no single answer to that. It depends what you're training them for. There's some evidence that short training programs can work as well as workers that have been trained through longer programs. Depends again what you're trying to ask them to do. What I think is clear is that things like supportive supervision is very important. So the quality of the supervision is an important determinant of quality of practice. And I think their CPD, continuing development, will be important, and having a career prospect, a career pathway. And some countries have taken an interesting approach, like the Philippines, for example, has a stepladder approach. So you can go in training as a community health worker, and you can progress up the stepladder, and if you're good, you might come out as a doctor or nurse several years later. So giving people a career progression may be one way of retaining high quality, incentivized, motivated people in the health system. And finally, the point about targeting that Kevin made about the perverse incentives of targeting certain indicators. And I think this is always a problem. If you target one disease, one condition, one age group, then almost by definition, you can't target everyone. So one way around that, of course, is to have cross-cutting indicators that reflect progress across a whole broad range of front. One of those is life expectancy. So it's quite likely that life expectancy, or possibly healthy life expectancy, might be included as one of the overall targets in the SDG arena. We shall see. And there's quite a big debate about healthy life expectancy versus life expectancy, which I don't really have time to go into, but both of them have some advantages. And the final point really is about ensuring that we do target and prioritize the poorest. So we go for interventions which will improve the health of the poorest. And one example, the one I gave earlier, was the cook stoves. Whereas if you can get clean home energy, you will, almost by definition, prioritize some of the poorest sectors of society, particularly women and children. And so it seems to me that that's the kind of intervention and target we should be thinking about.
Thanks, Andy. On that issue, actually, I would recommend that people take a look at the Adam Wagstaff World Bank report, because it has one particularly interesting finding relating to this, which is that if you look in inequalities in coverage of basic services, they're coming down relatively quickly across most countries, but that's not reflected in the convergence of outcomes.
No.
And the argument that they make is that one possible explanatory variable is that poor people are getting covered by very poor quality services, and so you're not getting the outcome results. So let's go over to this side of the room. So again, short questions as we get closer to the end. Thanks, right over there. Sorry to make you walk so far.
Hi, I'm Erica Hoganson from Crown Agents. And when we think about universal coverage for healthcare, and we think about we've been talking quite a lot about bringing in multi-sectors and thinking a little bit outside the box. I wonder if we've been talking still about integrating with nutrition, we've been talking about integrating with still thinking within the health sector. And I wonder, for example, our program in Zimbabwe, we're working with public health centers to be able to eliminate the user fee for pregnant women and children under 5. And we found that actually the biggest challenges we've had has been working with the local bank accounts of these health centers. And Crown Agents has a bank, so we're actually able to provide that type of technical assistance to the local banks. But what about other health NGOs, particularly local NGOs, that might be trying to provide those type of interventions but don't have the same sort of technical expertise?
Thanks, Erica. It's amazing that we're still talking about user fees in 2014, isn't it? But anyway, right over there. Short questions, thank you.
Well, I'm Tafullah Chaudhry. I am from Bangladesh. I have got 3 specific questions. 2 to Nepal, 1 to Professor Andy Haynes. Is cesarean sections in Nepal, I saw it probably 4.5%. According to WHO manuals, it should be within 6 to 10% should be okay. But I wonder whether it is not required, that's why you have got low cesarean section, or the doctors, as they don't want to live in the rural areas, so personnel are not available to do what is the reason? It may be that you are the right figure. In fact, my own experience is more or less same. 6 to 8% is like a cesarean should be okay. Second, is safe home delivery possible? To Professor Andy Haynes, universal health coverage, is it a partial health cover or total health care? What I mean, is it only comprising primary health care, secondary and tertiary, combination of all or partial? That is because no document, I do not see in universal health coverage, this is the present buzzword, everybody talking about it, World Bank, Business Organization, WHO, but nobody define it well, except the catastrophic implications. Thank you.
Thank you very much. Was there one right at the back?
Thank you. Lenny Wild from ODI. A number of the cases that we heard talked about the role of political will or commitment as a crucial ingredient in achieving progress. And if we look at universal health coverage overall, as I think the final presentation highlighted, well, that's also about a political strategy that's needed, including to buy in elites who otherwise may not be incentivized to support that system. Excuse me. So I wondered if the panel could give us their reflections on what it really takes to get that political commitment, what underlies it, what kinds of strategies are needed, what kinds of coalitions in order to get that kind of commitment to deliver on that kind of a reform. Thank you.
Thanks, Lenny. And one right over here. You're going to be very fit by the end of this session.
Lara Ho from International Rescue Committee. Just to add to the last question, in particular in fragile and conflict-affected states where there often is very little political will, what role can and should donors play in helping to generate that, and what evidence do we have for what works?
Thank you very much. Okay, I think one last one from David.
I'm glad a colleague brought up animal health issues. I think it's really important to remember that 600 million people on the planet live closely connected with livestock, and that many of the NTDs are zoonotic, and the provision of services in those areas is limited. Some of the best examples of zoonotic diseases derive from the problems of febrile illnesses, particularly in Africa, where the diagnosis of febrile illness is so flaky indeed. There are figures, and this was a meta-analysis in the Lancet. 61% on average of malaria is misdiagnosed. In dry seasons Africa, 90% is misdiagnosed. Despite the RDT issue, we need something which is going to sort out febrile illnesses, and that's particularly derived from the populations that are exposed to zoonotic infections. Rabies is another issue, but the point I would make about the sort of convergence of issues here and burden is that many of the NTDs are miscategorized in the sense that non-communicable diseases are the product of infectious NTDs. Cysticercosis, 31% of global epilepsy is caused by cysticercosis. Mental health, Moses mentioned. Cancers in foodborne trematodes, which are alluded to in the Cambodia report, these are not attributed to neglected diseases. They're put into the NCD category. And it's a massive underestimated burden. And we need to really look at that seriously in the future.
Thanks very much.
Oh, the other point is that all the drugs we're using, ivermectin, benzimidazoles, are coming from the animal health sector. There are very few drugs that come directly into human medicine in this area, and people are paying to deworm their animals, provide ivermectin and praziquantel in combination. They're prepared to pay for that, but they're not prepared to pay the cost of deworming in people.
Thank you. I think these are really important points, and clearly an area that's been somewhat neglected. I think this is going to be the last time back to the panel. So there are some specific questions, cesarean section in Nepal. I've got one, sorry, if I could just add, which is really building on the question that Lenny asked, which is about political will and commitment. Because I'm often struck by the fact that people use these words when they can't think of what else to say. You know, it's like the universal answer to every problem if we had the political will. And it's, you know, it's a bit on the tautological side. And, you know, one of the things that I'm struck by these studies, but also by other research in ODI, is that, you know, if you look at some of the initiatives that have really driven progress towards universal health coverage, they come from very unexpected political alliances. You know, there's an example from David Booth, actually, who works with Lenny from the Philippines, where, you know, a very curious coalition, you know, starting with the president, with a group of people in Congress, with civil society organizations, got together to close loopholes in the sales tax. And the funds from that, which $1 billion US, were transferred into the universal health system. You know, which is not something you'd expect in a country like the Philippines, actually. So it's a sort of left field type political alliance. And then by contrast, you get in India, you know, a government that talks endlessly about universal health care, but sets up health insurance schemes that are completely inequitable and inefficient in terms of delivering their objectives. And it's sort of interesting about, you know, why you get these very diverse political outcomes. And I, you know, I would like people just reflections on this question of, you know, how do we think about understanding the politics of universal health coverage in a, you know, in a more insightful way. So we go from left to right, not politically, but geographically this time. Andy.
Universal health coverage, my view very much is it cannot be restricted to primary health care. I think that would be an enormous mistake. And I think that was one of the problems with Alma-Ata, actually, that primary health care was dealt with too much in isolation. And as primary health care is connected to a functioning health system, it rapidly loses credibility and collapses. So to my mind, it has to be a functioning health system. Now, how that actually functions and which diseases it can cover will depend on the kind of, both on the political context, on the amount of resources available, and on the local epidemiology. And I think ultimately it is a kind of question of political debate and judgment. I mean, the UK has limits to its health system. It won't cover things that NICE, the National Institute of Clinical Excellence, you know, deems to be not cost effective. So every country will have to make some decision about how to use its resources. The important thing to do, I think, is to have transparency, to understand why the decision is being made, on what grounds, what criteria are being used, and to have a very active NGO citizen debate about what coverage should be. But also that shouldn't be static. So as the economy improves, the coverage, the extent of the coverage should improve, in my view. Political commitment, I mean, this is a very interesting area. It's not my area. I do think it raises the whole issue of intersectoral or interdisciplinary approaches to public health. And in my view, we haven't involved political scientists enough. We're not political scientists. And actually what we need is to engage political science more in this whole area of universal health coverage, advancing getting over the barriers to universal health coverage, what are likely to be the kind of effective policy levers, who are the key players. I think they will vary from country to country. I think in many countries, NGOs, citizen movements play an enormously important role, but that's not true in every country. And then finally, on one very specific point, this whole issue of febrile illness, I think is absolutely vital, because one of the things that concerns me is that much febrile illness, of course, is due to viral diseases. And as children are, as malaria is better diagnosed and treated, then the question is what to do with the large remainder of children who are febrile, but you don't know what's wrong with them. So are you just going to give them antibiotics willy-nilly, in which case you're just going to contribute to antibiotic resistance and boost up the health budget to not very little effect? So actually that's a problem we face here in the UK, is distinguishing between viral and bacterial illness in an acutely ill child. So it seems to me on that level it's something that high, low, middle income countries all share, and there need to be more resources into rapid diagnostics that will tell you, has this child got a bacterial infection or a viral infection? We don't even need to necessarily know which bacterial infection, but we do need to know they've got a bacterial infection.
Thank you. Moses.
Yes, just briefly, this thing about political commitment, I think we have to focus a lot talking about political commitment in the target environments. I think there's been a lot of political commitments, for instance, from donor countries. And the question they're asking now, how much are we getting? What's the commitment from the recipients? I think so we really have to make the difference between that and make that very clear.
Thank you. Fiona?
I think through this model that we're developing, this sort of multi-level approach, we hope to be able to sort of cut up or sort of open up a little bit this black boxes of what happens, what are the political engagement type strategies at these different levels. So in a way, you know, trying to dissect it a little bit and see what different actors or interests are at play at different levels, and then see how they interact with each other. So, you know, what strategies, you know, would one work at, would work at a more micro level? You know, is it about sort of giving communities a space or voice? Is it about patients being empowered? So it's that sort of level, at that micro level. And then we would work up, you know, what are the political strategies and spaces at a more meso level? So I suppose in a way it's like breaking it up a little bit and seeing, you know, what actually could work and what is working in different countries, and, you know, how could that inform us ultimately in sort of getting at issues of universal health coverage. So I think that's the way we're sort of trying to go, I think, and I think we're still exploring it. But comments from people here and yourselves in POGO would be great on that as well.
No acronyms. POGO means
Sorry.
Politics and Governance Group.
Yes.
If you would respond, maybe there was a specific question on the cesarean section as well.
That is our HMIS data of 11-12, and 12-13 we have 6%, and we have allocated money for referral fund in remote districts, in 16 districts, even for airlifting. Maybe that is 6% and 4.5% is true. But HMIS data, this is.
Mm-hmm. Okay, thank you. Joe?
We are promoting institutional delivery, not home delivery.
That means safe delivery is not possible?
No, possible, but
okay,
we are promoting institutional delivery.
We can actually continue
Safe
this.
institutional
We can
delivery.
continue the discussion after over coffee, maybe. Joe?
Maybe just a final point on the political will side of things. I mean, I do think that there's two important trends that we're certainly tracking, and one is, I think, the decline of influence on some of the donor aid flows that we'll see. I mean, we've peaked, I think, at about 135 billion, the latest DAC studies, and even so, that's a 4% on average decline year on year. And I think the challenge in the future is going to be the proportion of those resources and how we make better use of those resources. I don't think anyone can predict that there's going to be, you know, vast new increases, which leaves, I think, a big question on how we increase our ability to mobilize resources at a country level. And the question about sort of mobilizing political, well, I agree. I mean, it is a kind of off-used phrase for and more ambiguous. But in the end, I also think it's you know, many of the same lessons and case studies on successful advocacy and social change will be the similar kinds of studies or the similar kinds of lessons or tactics we need on mobilizing resources in the South. It's actionable evidence. It's about you know, making sure you can make a good case about the cost-benefit analysis to not just health ministers but finance ministers. It's about investing in civil society to make sure that they can hold their governments to account. It's about recruiting visible, vocal champions on these issues. And I agree as well, this kind of, you know, unlikely bedfellow alliances where you can bring people together who, for whatever reasons, have a similar self-interest or a kind of issue commonality. I think those are some of the ingredients. But I think increasingly, I mean, I look at it even from our own advocacy perspective. You know, we have a disproportionate representation in donor countries. I would hope in the next few years that flips, and our sort of burgeoning Southern advocacy takes a much more dominant role in the next decade or so.
Thanks very much, Joe. So look, as I say, thank you to all of the speakers, to Fiona for the brilliant overview, for everybody for their contributions. I also wanted to thank Susan Nicolai, actually, who's really held this project together and driven it forward over the last couple of years. So thank you to Susan. just a couple of quick parting thoughts that on the politics. That I'm very struck by, that if you read the Lancet and other journals, we've got this incredible volume of high quality evidence on the cost benefit case for doing this. That economically, actually, Joe, as you said, that the Global Commission made the point. They argue that a quarter of the growth in emerging markets over the past 12 years you can trace back to changes in health coverage. I don't know if that number's right, but it's an impressive figure. But it's still interesting that in the face of all this evidence, I mean, if you look at the debate in the US, where 40% of the budget is virtually wasted because it goes to rents to pharmaceutical companies or to insurers or private providers. But even attempts to do relatively modest progressive reforms, really stirs a political hornet's nest. And, for me, it just brings home how tricky this is. Identifying technically what the reforms we need are is sort of pretty straight. I mean, it's complicated, but it's somewhat straightforward as well. But the politics is really tough. And I am struck actually just with the point that one of the speakers made earlier about how we approach the narrative on this, because a lot of these debates are going on in our own countries. They're going on in the US, they're going on in Canada, they're going on in France and Germany. But when we speak about the underlying problems are actually very similar. So, how do you finance, deliver, support poor people to get in to a health system that's affordable and accessible at the point of use? And I do sometimes wonder, if we're approaching a point where maybe we need to stop talking about these problems as though they just affect people out there. And there are things about social justice and fairness that we're grappling with at home as well. So with that thought, there's good news and bad news to end with. The good news is that for those of you who are staying for the round table, there is lunch. The bad news goes without saying that those of you who aren't, I'm afraid, go with nothing. So sorry about that. But it's been a hugely constructive and informative discussion. So again, a very big thanks to all of the speakers and to you guys for firing tough questions at them. Thank you to everyone.